Thank you to the organizers, Yashoda Group, and especially Vishweshwaran for conceptualizing this program today. It is meant for the students. I think I'm audible otherwise also. But see, thing is that chest X-ray and CT scan cannot be taught in half an hour. So this talk is really not about the technicalities of an X-ray and things. But I would think of it as a capsule therapy. So if you have any doubts in between, I've tried to put up as many things as possible so that you can ease it out once you actually read it on your own. So it is not something which will teach you X-ray reading in a day or a CT reading in a day. We start with the slideshow. So first we will talk about the chest X-ray. When we interpret a chest X-ray, first thing is obviously to confirm the patient details. It, as silly as it may sound, but patients, it keeps happening in the ICU that you are doing multiple X-rays and you are fumbling with the names of the patient and you are interpreting the patient's X-ray in a wrong way. It happens a lot in our ICUs as well. And always ask for the previous imaging. So whenever you're interpreting an X-ray, X-rays, especially in patients who are in ICU, things are very dynamic. And otherwise also a patient who has come to you in your OPD, it is a good practice to ask for the previous scans. Because in X-ray, it's basically giving you only 30% picture of your lung anyways. So you need to compare it with the previous scans, right? Okay. This is a very important thing that you assess the image quality before interpreting, just like any other report which is to be interpreted. Look for the rotation. As you can actually misdiagnose many conditions just because the patient was rotated at the time of taking an X-ray. So these are the things that you should keep in mind. A patient should have had a good inspiratory effort. Projection should also be good. I mean, you should also know whether the patient's X-ray has been taken in an AP view or a PA view, and the exposure. So how do you judge on these qualities? I have listed the points. You can take the presentation later, but I'm just enumerating so that we don't waste time. But these these four things have to be looked into. Now, what does a normal chest X-ray look like? So look at this. This is the normal chest X-ray. You have a lot of lines and interfaces which you should focus on. And you should look at the right paratracheal stripe. These are the interlobular arteries. This is the right atrium. This area is the esophageal recess, which is a hidden area. We don't really focus on that when we are interpreting an X-ray. Then there is an aortic knob on the left side, the pulmonary trunk. Then there is a left atrial appendage. This is the para-aortic line. This border is formed by the left ventricle, and there is a paraspinal line. And this exposure is good quality because you can see the spinous processes, so the exposure is good. The diaphragms can be traced on both sides up to the vertebral bodies. Patient is not rotated because the spine is almost central to the clavicles. So all those things are good about this X-ray. And these interfaces and lines are important because they are going to help us in making a diagnosis. Now, there could be many approaches as you will go and read on your own. There could be an ABCD approach, ABCD, EFGH approach. Many approaches are given. Whichever way you are comfortable, idea is not to miss anything when you're seeing the X-ray. So what I follow in a routine practice is going inside out, where you look at the heart and the mediastinum and the Hilar first, then look at the lungs and the thoracic wall and the cage, and then go for the hidden areas, which I'm going to tell about. What do you see in the heart? So let us just, I'm not going to tell much detail, but what in a PA view should, what will you, if your heart size is enlarged, which chambers are you really looking at? So lateral X-rays are not very frequently done since the time CT has taken over, but just on a PA view, you should know that this shadow is left atrium. This is left atrial appendage that I've already said. This border is right atrium and not right ventricle. And the right ventricle will be somewhere at the base of the heart, okay? And the left ventricle, which forms the apex, is like this. So this is the picture of the X-ray, the heart on a normal chest X-ray. Now, these are the four figures. Can anybody say what is in A, B, and C? And I have already put the pointers also. Can anybody please raise your hands, or otherwise there will be no point of this session. Can you see something enlarged over here? What is enlarged here? Will it be right atrium? Look deeper. This is the left atrium. And on the other side, look at this. Then there is, can you see this pulmonary conus here and the pulmonary artery dilatation? Even this is enlarged. This is the right inferior pulmonary artery. And then this is the X-ray of a congestive heart failure. So congestive heart failure, I have put other points about congestive heart failure also because this is a common diagnosis which is made in our ICUs and otherwise also. So what all do you look? Again, this is made easy by the ABCDE. So A is the alveolar edema. You can see in the picture. Then there are curly lines which are seen on the peripheries of the lung, which are known as curly B lines, which depict interstitial edema. Then there is cardiomegaly for C, which is increased heart size more than 50% of the thoracic border. Then dilated upper lobe vessels. This is upper lobe congestion due to pulmonary venous congestion. This is redistribution. And then there is bilateral effusion usually. So not all the findings will be found in a patient. So there are stages of a heart failure. So depending on the stage, you will get either of these things. And this is also known as bat wing or butterfly sign, and this is the cephalization of vessels as they are called. It is also known as stag antler sign or hands up sign or inverted mustache sign. Now again, cardiomegaly is not only suggestive of congestive heart failure. So what can be other things that you can see with cardiomegaly? One is due to pericardial effusion. Can you appreciate the effusion in the CT now? This is the pericardial effusion. There are no other features of heart failure in this. Look at this, absolutely clean lung fields, and you have a pericardial fat. Actually, when CT was done, this is pericardial fat. And another patient, this is due to the pericardial cyst. Now, coming on to silhouette sign. So what is silhouette? We understand the silhouette is the border of something. Silhouette sign is kind of a misnomer. It is loss of the silhouette or the border, which is the silhouette sign. So normally you see the heart border, and when it is obscured, like this in this figure, then obviously there is some pathology going on. So you have two silhouettes importantly. One is on the left side, one is on the right side. If your left heart border is masked, then your pathology is in the lingula, okay? And if your right heart border is masked, then your pathology is in the middle lobe. So silhouette sign is very important for residents. Never miss that. Can you tell me the difference between A and B? Yes, you were answering, so you know about it. Can you tell me the difference between A and B? It is related to the silhouette sign. Can you see the heart border in this one? No. And in this one? But both have consolidation. So this is right middle lobe consolidation, and this is right lower lobe consolidation. Very good. Now coming to Hilar. So normal Hilar is 99% vessels, which are pulmonary arteries and few veins and lymph nodes. So mainly it is vascular. And left hilum is never lower than the right hilum, right? Right inferior pulmonary artery is visible in 94% patients, which we have already seen in our X-ray, and left in almost 60%. And when you have hilar enlargement, again I'm saying then don't really waste your time. I will give this presentation, you can take it. These are the causes of unilateral or bilateral hilar enlargements. So mostly they are infections. Most common in India are TB and fungal infections. Other thing which we commonly see is cancers, because lymph node enlargements, and pulmonary vascular enlargements that I've already shown you one X-ray already. Then in bilateral causes, sarcoidosis and tuberculosis again go hand in hand in India. And then obviously tumors like lymphoma and malignancies and vascular causes. This is about two signs which sometimes the residents are asked about: hilum overlay sign and hilum convergence sign. So hilum is basically a part of mediastinum. So it overlay tells you that whether the opacity is in the middle mediastinum or the hilum proper, or is it anterior or posterior to it. So if your visualization of the vessels is preserved, then probably it is not in the medial mediastinum, it is behind it or anterior to it. In hilum convergence, it tells you about whether it is a vascular pathology, pulmonary vascular pathology in the hilum, or a nodal mass. So normally nowadays these signs have no meaning except for the exam going people, because now CTs have made your life much easier. This is about hilum overlay. As you can see the vessels through both the things. So this is not in the middle mediastinum and the convergence. Since we are talking about the vascular enlargements in hilum, important signs about pulmonary embolism. Again, a thing which is commonly missed by the residents in the ICU. One of the commonest causes which can lead to in-hospital mortality. And you have these signs: Fleischner sign, which is enlarged pulmonary artery, Hampton's hump, which is basically a peripheral wedge-shaped opacity, Westermarck sign, Pala's sign, which is right enlarged descending artery, and Chang's sign is sudden cutoff in the artery. Knuckle sign is again dilated artery, which forms a knuckle-like thing, and bilateral effusions in 35% patients. This is how, these are the signs which you can actually see the Fleischner sign. Hampton's hump here. Westermarck is complete oligemia of the field. Knuckle sign, you can see the right inferior pulmonary artery forming a knuckle. The Pala's sign, and Chang's sign is basically sudden cutoff of the vessel here, and pleural effusions on both sides. These pleural effusions are very subtle, so you really pick them only when you have a keen eye. Mediastinum I'm not going to discuss much because you divide them into anterior, medial, and posterior, and really X-ray is not a good modality to diagnose mediastinal masses, so we go for CT scan imaging. One thing about mediastinum, because we are concerned about trachea, you can actually see the deviation of trachea, which can lead you to a diagnosis. Either it is a pull pathology or a push pathology. What do you think in this case? What is the pathology here? Anybody from the right side, on my side? What's happening to the trachea here? So it's getting pushed away due to you can see that the hard border is obscured, and there is an effusion also. Probably it's a mass with effusion which is pushing the trachea away. Along with that, you can see the contour of the trachea also if it's a well done X-ray. So you can look for tracheal narrowing, dilatations, any kind of aberrations in the, sometimes tracheal masses are also visible if the X-rays exposure is very good. Now last, we are coming to the lungs. So lungs, basically you can have these kind of patterns. Either you can have increased density in the lung, which can be in the form of a consolidation. In a consolidation, you will always have a preserved air bronchogram. Only then you can see the air bronchogram or the markings of the bronchial tree into the increased density area. That is the consolidation. Atelectasis is again increased density, but you won't see any air bronchogram which depicts a collapse, basically, either due to obstruction or a passive collapse. Then there can be a nodule or a mass, which can be multiple. So anything which is less than 3 centimeters is called a nodule, and bigger than that is called a mass. But it has to have a well-defined margin. Mass has to have a well-defined margin. Otherwise, you can call them non-homogeneous opacities, right? Then you have interstitial markings, just like these, very subtle. They are only prominent when you have a pathology in the interstitium, either accumulation of a fluid or thickening or inflammation. Then decreased density could be due to emphysema and cysts. So it's difficult to pick up decreased density in an X-ray because there are other factors which can lead to, but one important example of decreased density is a pneumothorax, which is picked up easily on an X-ray. So again, this table I will give to you, but consolidation pattern, how it can help you in making a diagnosis, depending on the history of the patient, you can go for acute and chronic conditions, which is fitting into your patient's profile. And with the bat wing appearance, you can have edema, PCP, and viral pneumonia, and reversed bat wing sign. When you have a peripheral picture and the hilar portions bilaterally are clear. So they are the signs of organizing pneumonia. You have seen a lot of that in COVID, actually. Reverse bat wing and eosinophilic pneumonia, radiation exposure. Then you can classify them as diffuse shadows, lobar, or multiple ill-defined things. So you have to really point it out how your consolidation pattern looks like, and then you can formulate your diagnosis. If you have atelectasis pattern, it can be either due to, I said, resorption is basically obstructive atelectasis, so it could be a mucus plug, commonly seen in asthmatics sometimes, or ABPA patients, tumors, or foreign body in children and old age. Then relaxation is passive atelectasis due to effusion, pneumothorax, or atelectasis. Round atelectasis is again due to fluid. In mass-like pattern, you can have nodules and masses. Again, the DDs are almost similar, mostly infections and vascular causes and tumors. So these differentials you can take from this presentation later on. Next, last thing in the stepwise approach was looking at the thoracic wall. Just to give you the brief pointers, scan the margins entirely and carefully. Look at the pleural surfaces, diaphragms, angles, ribs, bones, other soft tissues. Always compare both the sides. Look for artifacts. So, before calling something as pathology, look for skin folds, hair plait, the neck line, breast shadows, or the artifacts through the ICU tubings, the lines and the artificial valves and the pacemakers. So always focus on those things. And in pleura, you have to look for effusion, pneumothorax or hydropneumothorax, pleural plaques, calcification, masses, and then also look for ribs and bones. You can find pathologies there also. Just briefly telling you about the pictures. Metastatic effusion like this, and there are masses on the other side. There is a pneumothorax here, if you can actually see the pleural line here. So this is a pneumothorax here. Loculated effusion is also there. And you have, again, my picture is blurring, but there is a deep sulcus sign here, which is suggestive of a pneumothorax. These are pleural plaques, which you commonly see in asbestosis. Pleural calcifications are seen, which are basically signs of old infection or maybe a hemorrhage, something which has been long standing in the pleura, and rib fractures. Hidden areas, there are, whenever you complete your assessment of an X-ray, just look at these hidden areas. A normal looking X-ray, especially focus on these areas, the apices of the lung, the hilar regions again, retrocardiac left area, below the diaphragm and behind the diaphragm, the peripheral zones and the esophageal recess. So this is a quiz before I wind up X-rays. Can you tell what is there in first? This is about the hidden areas. Can anybody tell?
Who needs the stethoscope? You have nothing to lose. Answer.
Take good 2 minutes here, then we proceed towards our CT scans.
Mansi, can you give them a hint at least? It's a
Yeah, so look
X-ray.
for something in the apices here. Apices look normal, and always compare bilaterally. Can you see something here? Look at the right side. Apex is almost clean, and can you see here? So there is an opacity here, which is not there on the right side. So this patient, when CT was done, there was a part GGO, part solid nodule here, mass here, okay? And what about this X-ray? It's visible here also, but again, I don't expect lateral X-rays to be, understood in one day. So just for that. And in this area, look at the retrocardiac area here. Does it look more dense the rest of the cardiac shadow here?
So whoever says answers for this question will get a stethoscope separately. So
how many stethoscopes do you have?
I've already said the answer then.
Anybody volunteering to
look at the density of the heart shadow elsewhere and the retrocardiac area. This area definitely looks more dense. So when CT was done, there was a light lower lobe consolidation. Okay, so the point is CT definitely will give you the entire picture. But in an OPD, a patient who comes complaining with chest pain and fever for some days, don't ignore this patient just because you think it's a normal X-ray. So now coming to CT chest, again, it's a big topic in itself. Next 15 minutes, we focus on only the important things, right? So CT, it is indicated for many conditions like lung cancer staging, mediastinal pathologies I have already said. Cardiac, we do CT and MRI both. Then pericardial disease. The lung parenchyma, I'll come to that. For trauma, again, sometimes you need to do a CT scan. Embolism, it is one important indication for doing a CT pulmonary angiography. And pleural abnormalities, again, you do a contrast CT. So for contrast CT, what are the requirements? It aids in assessment of mediastinal structures because it helps in delineating vascular structures from nodal masses, because the mediastinal structures will not be very clear if your contrast is not given. Sometimes the mass is merging with the nodal mass or the malignant mass. So then contrast is indicated. Now, since CT has a lot of indications and we can't really go into details of all, most common indication to do is when you do for parenchymal diseases, and next 15 minutes we spend on that only. Just before we move on to that, few pictures I want to show you. Can anybody say what is there in A? See, if we don't make it interactive, you will all sleep. So there's no point of this discussion then. Anybody just raise your hand, what is there in A?
And what cut is this? What is
and
this
what
telling
cut
you?
is this? I will also tell about the types of cuts. So this is an axial cut. Okay, this is showing. What is it showing? It's a contrast enhanced CT showing necrotic lymphadenopathy here. Can you see? Right paratracheal? Okay. And in B picture, again contrast has been given. Can you see this shadow in the pulmonary artery? This is a saddle thrombus. Okay. And what about this? Again, it's a thrombus which are infarct. Okay. Can you see its origin from the pulmonary vasculature here? And what about this? Dilated pulmonary artery. The cutoff is 29 mm. If it is more than 30 or 35, it's definitely enlarged. So in this patient, it is 35. Now, what is high resolution CT scan? Because as a pulmonologist, you'll be hearing this term a lot nowadays. It is useful for scanning lung architecture, and we're doing it without IV contrast. It's a non-contrast CT scan. It acquires thin, non-contiguous slices, which are almost 1.5 mm thickness. And the radiation exposure is almost 90% lesser. So when do you do for this kind of a scan? It is predominantly done for interstitial lung diseases, for delineation of the architecture of the lung, sarcoidosis, bronchiectasis, emphysema, and atypical infections. Why atypical infections have been kept here? Because atypical infections also proceed starting from interstitium. Pathophysiologically, they involve interstitium more. So again, it's all coming down to the interstitium. So before we interpret, we should know what is important in anatomical understanding of the structures on CT thorax. It is again a complete lecture, at what level what structures are found. So I'm not going into details of that, you have to read about it. Possible anatomical orientation. So this is the axial view that Dr. Arjun was also talking about. Axial view, you have a coronal view, which is front to back, and you have a sagittal view, which is side to side. So these three views you should be aware of. And the other thing that you should know about is anatomy of secondary pulmonary lobule. What is secondary pulmonary lobule? This is the smallest functional unit in the lung, which can be seen from through the naked eye on a CT scan. So this is the structure of the pulmonary lobule. You can see that there is a centrilobular artery in blue. Then there is a terminal bronchiole, which is visible, the airway that we are talking about. And the lymphatics and the veins are in the interlobular septae, which are in the red and yellow. This is the centrilobular area that we are talking about. This is the opacity in the centrilobular area. Okay? So are we, now because we are interpreting the CT scan with these areas only. So this is the perilymphatic area. This area is the perilymphatic, and this is the centrilobular area. Now the structured approach to HRCT involves what is the dominant pattern? Is it reticular pattern? Is it nodular pattern? Is it a high attenuation pattern? It is a low attenuation pattern. These four questions you have to ask. What is the location of the pattern? So is it centrilobular, perilymphatic, or it is randomly distributed? Next is whether it is upper lobe predominant disease or a lower lobe predominant disease or a central or a peripheral disease. And next is any additional findings which we have seen through mediastinum is pleural fluid, lymphadenopathy, and other things. Now, what about the reticular pattern first? So there are two things that you have seen. Reticular pattern means zigzag lines seen on the CT scan. Too many lines seen on a CT scan. So first thing you should look at is presence or absence of honeycombing, which are small cystic areas. They are usually seen in the peripheral and the subpleural regions, and they are usually in several contiguous layers. So you have to have at least 3 to 4 layers of a cystic area, which are normally multiple variable sized, right? The other reticular pattern which is important to be seen is septal thickening. The septal thickening, I've already shown you the diagram of secondary pulmonary lobule and the septum. So if they are thickened and prominent, they will lead to smooth or irregular thickening of the septum. So let us look at some patterns. This is smooth septal thickening. Can you appreciate the septum here? These are the septum which are prominent. Here, here. But they are smooth, they are not beaded, right? And also you can appreciate the increased density, or the GGOs that they are called, increased density areas, are in the gravity dependent areas. This is highly suggestive of cardiogenic pulmonary edema or heart failure. We get many calls to do bronchoscopic and bowel lavage in patients because they are in fluid overload, and we always tell them just do dialysis for your patients. Okay? Irregular focal septal thickening. If you have focal involvement, you can think of lymphangitis carcinomatosis. If it would have been symmetrical or bilateral, I would start thinking on the lines of an ILD, right? Then this is honeycombing, several contiguous layers in the lower zones, including the periphery, and there are cystic areas, also seen as traction bronchiectasis here, right? So this is not honeycombing, this is traction bronchiectasis. First was reticular pattern, next is nodular pattern. So nodules that you see on a CT scan is randomly distributed nodules, just like these, or a centrilobular nodules that we have already discussed where to see, and then perilymphatic distribution along the septae. Can you appreciate this? So when you see perilymphatic diseases, basically the spread is through lymphatics. Most common involvement is seen in sarcoidosis. Can you see so they'll be along the fissures, they'll be along the septae, okay? So just look at this fissure, it is all completely beaded. You can see nodules along the fissures and the septae, right? The other is centrilobular GGOs, which are seen in the centrilobular areas. They will be away from the pleural margin of the CT, always. If they're arising from the pleural margin, again, they are perilymphatic nodules, right? So centrilobular nodules will be some part away from the margins of the pleural line, and they're seen GGOs. This is a CT patient of hypersensitivity pneumonitis, and then randomly distributed, they have no preference. They can be in the pleura also, in the lung also, centrilobular, anywhere. So these can be in tuberculosis or infections. One thing which can be seen in centrilobular nodules is tree in bud appearance. Can you see this tree in bud here? Just like a budding tree. So it suggests, what does it suggest? Don't say tuberculosis. It suggests endobronchial spread or airway involvement which has active inflammation going on. So TB is common in India, but it is not the only differential here, right? So let us look at the patterns now. Reticular, with smooth septal thickening, irregular, and honeycombing. These are the differentials. Again, the slide will be given. Nodules, perilymphatic, centrilobular, and random. And in tree in bud, infections are one of the causes, but again, they can be in airway diseases, asthma, IBP, and aspiration pneumonitis. Then third thing was high attenuation pattern. High attenuation is always like consolidation or a GGO. So these are the common causes of GGOs in acute and chronic conditions. And also the location of GGOs will help you make a diagnosis. So if you have upper lobe predominant GGOs, you can think of respiratory bronchiolitis and pneumocystis pneumonia. Lower lobe predominant, you have UIP, NSIP, and DIP patterns. And centrilobular, I've said hypersensitivity, I've already shown a CT, and respiratory bronchiolitis again. So they are around the centrilobular area. What about mosaic attenuation? These are two variants where you have a combination of different patterns. So mosaic attenuation is basically when you have different attenuation areas in the same CT scan. What does it depict? Either it is a airway pathology or a vascular pathology. So let us look at this constrictive obliterative bronchiolitis. You can see there is increased GGOs here and a normal attenuation here. Similarly, in chronic PE patients, you can have areas of increased GGOs here and there is low attenuation areas here. And as you can see, there are prominent vessels here. It looks like to be a vascular pathology, right? So, you would think of chronic pulmonary embolism. This is a patient of hemorrhage and hypersensitivity pneumonitis. Then we have a crazy paving pattern here, which is basically GGOs along with prominent interlobular septal thickening. Okay? Last was low attenuation. Low attenuation can be in the form of lung cysts. This is emphysema, which is centrilobular. You can also have paraseptal emphysema. Again, that will be low attenuation. Then traction bronchiectasis. I've already shown one CT with a honeycombing. And again, signet ring sign or bronchiectasis. These are all signs of low attenuation areas. Now, the second question was distribution within the lung. So if you have upper zone distribution, you have sarcoidosis, silicosis, pneumoconiosis, emphysema, PLCH, HP. These are in the upper lobes. If you have lower lobe predominant diseases, you think of pulmonary edema or ARDS and UIP pattern or NSIP pattern. Then in central zones, you have sarcoidosis and bronchitis. And peripheral zones, we have already seen in X-rays also. It is either organizing pneumonia, eosinophilic pneumonia, or interstitial pneumonia. Additional findings, you can have hilar adenopathy and pleural effusion, and these are the differentials which can help you narrow down your diagnosis further if you get your hilar lymphadenopathy or effusion. So with that, you can actually make a diagnosis of diffuse parenchymal lung disease. You can narrow down your differential based on your CT pattern, distribution, and ancillary findings, and supportive clinical history and lab workup. So if I get an NSIP pattern with a serological workup positive for CTDs, then my diagnosis will be CTD-ILD. If I don't get a cause for NSIP pattern based on my description, then probably it is a idiopathic NSIP. And one important, before NSIP is hardly idiopathic. So before labeling NSIP as idiopathic, thoroughly look for CTDs. IPAF is a very common entity missed by pulmonologists, so involve your rheumatology colleagues in making a clinical diagnosis, and also look for drug-induced NSIPs. We usually miss those. And then you have to look for fibrotic or non-fibrotic. Just saying the pattern of CT scan is NSIP or UIP, nowadays it doesn't work. So either you have to say it is a fibrotic ILD or non-fibrotic. So the signs of fibrosis are complete architectural distortion, which you will find in most ILD patients. But presence of honeycombing with or without traction bronchiectasis is a sign of fibrotic and ILD. Otherwise, if you see predominantly septal thickening and GGOs only, then don't say it is fibrotic, okay? Then the next thing nowadays, the new term which has come up is progressive fibrosing ILD. You have to see the patient's follow-up CT scans over years. Maybe most patients have a bunch of CTs which have been done in 3-4 years. And with that, based on your assessment, you can make a diagnosis of PF-ILD also. There are criteria for that.
So we need to sum it up.
Yeah, just a couple of more slides. So bronchiectasis is basically, I'm just going to show the CT findings of bronchiectasis. You have a tram track sign, signet ring sign, this is signet ring sign, string of pearls sign, and bunch of grapes as seen in this CT scan. And how do atypical infections look on CT? These are GGOs like in mycoplasma, chlamydia, COVID-19, and pneumocystis, which is upper lobe predominant GGOs. And can you identify the signs in this picture? Last two are just quiz slides. What is that?
So
Hello and?
no one
Just
wants
hello.
diagnosis from you. Identify the pattern. Try to look at the lobes which are involved. Is it the upper lobes or is it the lower lobes? So towards...
So this is a nodule which is GGO based nodule, and you have a surrounding area of lower attenuation. So this is the halo sign that we are talking about, and these are the list of differential. Again, halo sign does not mean invasive pulmonary aspergillosis. There are a lot of differentials. The most common is basically cryptogenic organizing pneumonia actually. But in immunocompromised patients, you can have infections more. And this is, what is this sign? This is reverse halo, or what are the other names for this sign? Atoll sign. Though you are not raising hands, so nobody is getting a stethoscope. You have to raise your hand and then get a steth. This is reverse halo or bird nest sign, right? So you have seen a lot of it in COVID pneumonia again. And last quiz, now you have to raise hands, only then this is the last slide. Yeah, take home message. Yeah, you say. Tell. Which one is crazy paving pattern? Huh? First one is crazy paving pattern. Do you all agree with him? Yes, girl. Girl in blue, yes. You answer. Second is crazy paving. And this one? This is head cheese sign. So nobody answered actually. Again, I don't know whether Vishwesh is going to decide who gets the prize. This is triple density sign, very specific for HP pneumonitis. And this is crazy paving. Again, it is not specific for alveolar proteinosis. There are again many causes for that. So take home, I've already said again, there's no need to take home messages, just that HRCT scans are most important for ILDs and they should be ordered. So this is about my presentation.
Wait.